everyone. We're thrilled to have such great interest in this discussion. As healthcare organizations reopen and navigate delivering care during a global pandemic, it's critical for us to come together to share lessons learned, best practices, ideas, and insights. So we here at the Luma Health team appreciate that each of you have taken the time out of your extremely busy schedules to do just that. So I'm Kristen Folder. I work with Luma Health as their public relations agency. So you're not going to hear much from me for the rest of the discussion. I'm just going to do introductions. So I'm going to go around and say who each attendee and participant is, and then I'm going to turn the mic over to Adnan Iqbal, who will be facilitating the conversation today. So we have several areas of health represented here, and I'm going to start with the participants that represent specialty practices. So Dr. Tashfeen Ekram is a radiologist at Alta Vista Radiology and co-founder and chief medical officer of Luma Health. Hi, Tashfeen. Thanks for joining us.
Hello, how you doing?
Well, we have a packed crowd this morning, which is awesome. So thanks for taking the time. Dr. Medhavi Jogi is from Houston Thyroid and Endocrine Specialist. Hi, Dr. Jogi.
Hi there. How are you guys?
And Chuck Leader is Chief Informatics Officer at Houston ENT and Allergy. Hi, Chuck. Nice to have you here.
Nice to meet you and see you all and participate in this discussion.
Okay, now we're going to switch over to the representative we have from Community Health. Dr. Edgar Chavez is CEO at Universal Community Health Center. Dr. Chavez, thanks for joining us.
Good morning, everyone. Happy to be here.
And thanks, Kristen. We have two individuals representing the health systems. The first is Bharadwaj, who is the VP of Digital Innovation at Franciscan Health in the Midwest. Hi, Sri. Thanks for joining us.
This is Sri. Can you hear me?
We can.
Okay, great. Thank you.
Thank you. Great to have you.
Thank you.
And then we have Marlena Kane, who's Associate Administrator for Consumer Solutions and Access at Keck Medicine of USC. Hi, Marlena.
Good morning.
Okay, and then as we've all heard, we have one industry analyst, Adam Barrington, who is Research Director at CLASS.
Hi, good morning, everyone. Good to be with you.
And then lastly, three industry leaders. We have Aditya Bansad, who's the co-founder and CTO of Luma Health.
Good morning, everyone.
Who is wearing a collared shirt for us all this morning. Thank you.
Very unusual for me.
Very dapper. Catherine Howe, who's the Director of Healthcare Digital Transformation at Cisco. Catherine, thanks for joining us.
Thanks for having me. Good morning.
And Barbara Casey, who is the CEO of Nectar Strategic Consulting. Thank you for joining us, Barbara.
Hi, thanks for having me. It's great to be here.
Glad to have you. And then lastly, but not least, we have a few representatives from the media who will really be driving today's discussion with their questions. They will be directly talking panelists with some questions that they have later on in the discussion, but some of the questions that they did in advance have also been worked into the conversation that Adnan will be starting with everybody. First up, we have Kimberly Leonard, who is the senior healthcare reporter at Business Insider. Hi, Kimberly.
Hi, thanks so much for the invite.
Of course, we're thrilled to have you. Peter Wehrwein, editor of Managed Healthcare Executive. Peter, it's great to have you.
Thank you.
And then we also have Mackenzie Holland, who's a writer at Search Health IT with the Tech Target team. Hi, Mackenzie. Good morning.
Hi, good morning.
Thanks for being here. Glad to have you. So we have a lot of incredible individuals with lots of expertise and insight. Don't need to waste any more time, and we can get right to the conversation. So Adnan Iqbal is the CEO of Luma Health, and we'll be taking it over from here. So Adnan, it's all yours. I'm going to be quiet from here on out.
Thanks, Kristen. First and foremost, again, thank you everyone for joining. Happy Friday. I'm super pumped to have everyone together and really excited to hear from everyone. I'll kick it off with a handful of questions because I'm just as eager to pick your brain as Kimberly, Mackenzie, Peter, and Jared are, and then we'll turn it over to them to ask a handful of questions as well. I want to make sure we hear from each and every one of you. So would love for you to please keep your answers to 2 minutes or less so that we get a chance to hear from everyone on the panel today. Does that work? Right. So really, I think that the thing we're finding first and foremost is that COVID and the pandemic is changing really every aspect of our life, and that all of us who are involved in the healthcare space, many of you as direct healthcare leaders, it's really changing the way you think about delivering care, how you really think about how patients want to engage with care, and your entire overall operation. So the first question that I'll really ask is really for Dr. Jogi. Dr. Jogi, as you know, one of the leading endocrinologists in the greater Houston area, really being on the front lines of treating chronic care patients. I'm sure you've seen a lot of changes to the way you deliver and will continue to deliver care, not just now, but going forward. So what are some of the top things that you've noticed or already implemented in terms of the way that things are changing for you?
So there's two parts to that. The biggest change is that I have gotten to accelerate what I've always wanted, which was virtual care. And so I was doing about 20-30% of that. Now I'm about 90%. And that is something near and dear to me. And Luma has really accelerated how I can do that. I've already used Luma to kind of push video and digital methods into the way I interact with patients. And then the second thing is when I really do have to go back to the clinic, because I'm not going back to the clinic very often, and I don't plan to. And the reopening in my mind is a reopening of what virtual care can really be. And I only go back to the clinic a couple days a month. And that is when I'm there, we have an infinite waiting room now, and we can also use Luma and technology to make the entire building our waiting room. So there's a lot of social distancing that's happening.
Awesome. Dr. Karam, you of course see a variety of patients all across the country with AVR. What have you seen as some of the biggest changes?
Yeah, I think one of the most challenging things that we've seen is that patients don't perceive imaging as a necessity all the time. If you get hurt and you have to come to the ER, then obviously it's a necessity, or if you need to go to urgent care. But if you're doing long-term screening, for example, mammograms or screening for lung cancer, patients don't perceive that as something to be done. And now we're having a lot of challenges trying to help patients understand that, it's not, you can maybe delay it for a little bit, but having delayed a long time, it actually has a harmful impact. So I think as radiologists, what we try to do is have a better connection with our patients, understand their perceptions of why they're scared to come in, and help them understand the kind of procedures we put in place to help them come in sooner for those not emergent imaging. So that way they do feel comfortable that we're taking the appropriate measures to make sure that they feel comfortable when coming in.
Fantastic. Thank you. Dr. Chavez, you of course are training some of the most underserved patient populations in the city of Los Angeles. It's of course core to your mission at the University Community Health Center. I'd love to hear how COVID has changed the way UCHC delivers care in your environment. Have you made physical changes to your offices, your workflow, your exams, and what have been some of the sticking points you've noticed both from your own team's perspective and from your patient's perspective?
No, absolutely. I think that for us, one of the biggest changes was to convert to telehealth. Historically, underserved communities are not very big on telehealth just because of the resources, because of the disparity of internet access. And so early on, we've always been sort of a technology-driven health center. So we had iPads, we had a whole bunch of things. But one of the biggest challenges and changes that we've had to make was to be patient with the technology patients have and to become educators of the benefits of telehealth to this population, because historically they don't feel that they're getting care if they're not coming face to face with somebody, because that has always been the model that has been pushed for the health centers. That patient has to be within the four walls of our clinics. But with the COVID, the laws and the guidance changed, and so now they're allowing us to do telephone visits. They're allowing us to do televisits, video visits, and so we've been really good at converting, educating people, using all kinds of ways to communicate with them. Using Luma Health for us has actually been very helpful because it has allowed us to, for example, when the pandemic hit really big back in March, we had to let everybody know not to come to the clinic because we converted our clinic basically virtually from a Friday to a Monday. And so during the weekend, we had to let everybody know, hey, don't come in for your appointments on Monday. Everything is being converted to televisits. And so that was really good. We were able to do that in like one step and convert to telemedicine right away. And people got that information through a text, which is great. We didn't have to get on the phone and call people. So, but that has been one of the biggest changes, getting people to understand the benefit of telehealth, and then also guiding them through the process of how to join telehealth so that, you know, we can see them.
Hey, Dr. Chavez. Sri, you wear a variety of hats. You know, given your focus on delivering innovation at one of the largest Catholic health systems in the Midwest, what are some of the biggest changes you're seeing in the way Franciscan Health is really delivering care?
I mean, we transitioned to telehealth virtual visits model pretty quickly, drove up our uptake in the virtual visit process. The bigger innovation truly is in the inpatient area, right? I mean, almost everybody is doing virtual visits, and that is now becoming a commonplace commodity, kind of, in a way. But I think let's take a step back and look at what the patient is experiencing if and when he gets admitted, right? And what we are trying to do is to reduce the length of stay so that we can admit more patients, see more patients. So to that extent, we actually started doing multi-specialty rounding with several physicians, like you take a pulmonologist, a cardiologist, and an enteroperson, a hospitalist, and so on. Bring them in a room. Don't need to have the PPEs back in and out with the patient. So you create a mechanism, a technology mechanism that has the hospitalist or a nurse or one physician in the room and the rest of them outside the room do interdisciplinary multi-specialty rounding at outside the room, come up with a care model that will accelerate the patients to get better and reduce length of stay. We've been able to achieve that extensively well across several of our hospitals, purely because the focus was on making sure that COVID-19 patients get better, similar processes, standardized structures and workflows, and get the patient to get the benefit and move them out of the hospital into what we call a home health, or mostly home health, but in some cases nursing home where necessary. That innovation that we've done in the hospital by bringing in several physicians into a technology that really helps engage that has actually changed the way we are going to be probably looking at practicing inpatient capabilities in the future.
Awesome, thank you. I'll switch themes here a little bit, and we'd love to hear from some of the panelists. You know, we heard a lot about telehealth, but really, you know, what role does technology play beyond telehealth and really reopening healthcare in your communities and as you see in the country at large? And Adam, I'd love to kick off with you, just, you know, with Klaas being one of the leading analysts in this space. Of course, we heard this echoed from the panelists here in your research that telemedicine has been a large change, and you guys have done a lot of research on telehealth in particular. But what more can you share, and what really has surprised you from an overall technology standpoint?
Yeah, the main surprise has been just how quickly the market has shifted and how organizations have had to adapt, both patients, vendors, providers alike. And telehealth is absolutely the story we're hearing. We've interviewed hundreds of providers over the past few months, and by a measure of 3x, they're talking about virtual care, telehealth, kind of like the gentleman that just spoke. And there's many capabilities I think we're all trying to figure out. As far as other things beyond that, virtual care pieces, organizations are asking us about remote check-ins and self-scheduling, and a lot of these things that we're hoping we would see, but they've just been absolutely accelerated. I spoke to an organization just yesterday, in fact, that was talking about designing a hospital at home strategy, even talking about how to offer emergency services. And this was really unique. They described it as treating the patient in the field and even going beyond that. A patient could call a number and they would do some phone triage and understand if they need to come in, if an ambulance is needed, if other things could be done at home, or if a clinician needs to be sent to them. Really interesting conversation. And obviously this was on lower acuity things with the goal of reducing visits, keeping the patients protected, reducing admissions, and keeping them at home. But it was they were describing one step further, offering fluids, IVs, some of these mid-acuity things. So bottom line is healthcare is absolutely different, and telehealth is here to stay, and we're hearing similar numbers as to what was described.
Awesome, thank you, Adam. Dr. Jogi, I know you've been a big user of technology, and actually, even pre-pandemic brought elements of the exam room and interaction into the patient's home. Really, how do you think about what the team has shared thus far? And really, do you think telehealth is going to increase healthcare utilization, which I think the consensus here is yes, but will it make costs go up and down? And really, how will you know that you've hit overutilization with virtual health and more of the digital capabilities?
So I think that's, what Sri was saying about the hospital and how they're doing things virtually. I give patients, we pushed self-scheduling and a lot of digital health by giving patients no choice, by saying, you must do this if you want to be in my clinic. That doesn't apply to a community health organization where I do work as well. It's hard to apply that there. But now we also are now having a no choice situation in a lot of cases because of the pandemic, which is kind of forcing the hand of everybody. So I've been doing self-scheduling and the digital stuff for a while, and now it works really well. Does it increase? One interesting thing about the hospital is that I get patients self-scheduling who are in a hospital who are asking me for an opinion in a hospital that I don't have privileges in, and saying, hey, I just saw an endocrinologist. He walked out the door, and I need to know what you think. That's weird, right? There's a lot of weird barriers that are artificially placed for reasons that may have made sense pre-March 2020. And so my answer to the question of is it going to increase utilization? The answer is, of course, yes, but I've divided that into three parts. Access, of course. So the more access you have, even if you're sitting in a hospital bed, awesome. I welcome it. Can I do that? Nobody knows. Does my malpractice attorney understand it? No. Did they have to spend 3 hours calling somebody and not have an answer? Yeah, that doesn't make it. There's a lot of weird questions about artificial barriers, but the access is going to definitely increase. Is it right or wrong? Well, that comes down to is the care that's being provided correct or not? Am I gouging a patient or not? Is it good care or not? And that comes down to the integrity of a physician or whoever's providing the care. And so I would say from a medical perspective, I'm providing more access. And with Luma, I'm quadrupling my access because I can do things faster and more efficiently than I did myself 5 years ago. So, and I feel like I provide the right care. So if the patient wants to see me every 5 minutes, so be it. I mean, I have tons of doctors and I would love to be in contact with them every 5 minutes. If he's on a walk, great. If he's going to get paid for it, great. Can I pay for that? Probably. Can another person? May not. So the third question here is, if you really need good care, why not get tons of opinions? I would welcome my patients to get 20 endocrinology opinions from all over the world in the next 5 minutes and then tell me what they think. We're all experts now. So the third part is the economics, and that's way above my pay grade. But the way I view it, to answer that question, is if this is a supposedly finite resource, healthcare, then how do we accomplish anything with finite resources? Well, you could just create more somehow, which is possible, make it more efficiently accessed, or create sovereign doctors. And so telehealth, it just basically exposes the fraud and the waste of how healthcare administration's impact is on healthcare, which is basically a bunch of waste. So, all we have pre-COVID is what we're having is an exposing the siloed and enclosed access we've had to care. That's what drives up prices. It's not the access. That's what
Thanks, Dr. Jogi. Catherine, you spend a lot of time, interacting with and speaking with healthcare executives at some of the largest systems across the country. This question comes from Mackenzie with Search Health IT. Really, what have you been hearing about from your healthcare clients, and what tools, technology are they specifically asking about right now? What's top of mind for them?
Hi, Adnan. Good to see you again. Thanks for having me. And thanks for the question. Listen, we at Cisco have been in the healthcare business for many, many years, 20 plus years, and have worked with our hospitals and clinicians for years to kind of anticipate this very thing, this day, right? Broad scale adoption of digital technologies along the patient journey. And so we are ready. And what we're seeing is, of course, what the others have mentioned. And Dr. Jogi, going to 90% virtual visits, we're seeing that all over the country, all over the world, massive increases in the use of telehealth. But what we're seeing, Adnan, which I think is the right way to look at telehealth, is that beyond the video encounter itself, they're looking at the path to get to the video encounter. That too will become a limited thing, right? So when you look at the telehealth system, how to deliver telehealth, you're talking about 3 layers. The video call itself, of course, but then you're talking about the contact center, which is a major hub for scheduling and rescheduling and wait listing and all of the things, and consults, right? And then that patient engagement layer, which you all, that's your sweet spot, right? Reaching out to the patient in what we call sort of those consumer types of engagement touch points, texting and chatting and bots and ask a quick question on demand. And so those 3 layers are coming together to create the whole telehealth delivery system. And of course, where I am in the heart of the networking world at Cisco, we stitch all that together with security, with our WebEx platforms, and we've been doing that at scale for many industries for many years. One of the things, and it was mentioned, that we are seeing a rise on right now as we're getting towards not post-pandemic, but the tail end of pandemic, are the technologies from the consumer industry that allow you to track and trace, right? So our Meraki business using cameras and Wi-Fi with location-based analytics so that hospitals for the first time can manage their venue. They need to know, just like a Marriott or a cruise ship or any other kind of large environment, they need to know how many people are in and how many people are leaving and what's the right threshold for distancing. And then if there is, heaven forbid, contamination or an exposure, how do I contact all the people that were here last week and may have been exposed, right? And of course, technologies like Luma, I can text, and somebody mentioned being able to text people immediately to say, don't come into work tomorrow. That same solution is going to be used to text you to say, you may have been exposed. Click here if you've got any of these symptoms or if you want to have a consult. And now you're getting to that video call. So the whole system is finally coming together, which for the last 20 years, that's what Cisco has been preparing for. And we are here ready to deliver that to healthcare.
Thanks, Chris. Thanks, Katrin. Marlena, you also have worn a number of different hats and really have always been playing the role of understanding the patient and helping think through how to best deliver patient access for very large systems. Would you say that what you're hearing from the panel echoes what you're looking at? If not, what other technologies are you considering as you think about phased reopenings, a path towards a new normal, and also, of course, be prepared for any potential relapse or subsequent waves of the current pandemic?
Yeah, good question. Thanks, Adnan. I think I do echo what a lot of others have said. I think that a lot of the things that health systems are thinking about now are things that they were thinking about before. It's just about accelerating it and bringing it in a lot faster. Of course, top of mind is access. Not only thinking about the pent-up availability or access that we have because of COVID, but with the pivot to telehealth actually opens up an opportunity for growth in different areas. So really need to be not only thinking about how do we make up for lost appointments and visits, but also how do we pivot to grow where we know we can and want to. Telehealth, lots of conversations about that. I think my big concern with telehealth is making sure that systems have 1 to 2 reliable platforms that work well the first time a provider, physician tries to use it or team member. What I'm seeing and finding is that there's multiple options and they're not working very well. There's not a whole lot of trust every time. So I'm trying to make sure that systems are really thinking about the 1 to 2 that work well. I think a final consideration is something that I hadn't really thought about until I'm kind of in the here and now is how do we leverage technology to do the things that are now consuming more human capital based on what's going on with COVID? For example, in a call center agents are now having to spend a lot of time explaining to patients what our safety precautions are. They're having to spend a lot of time doing screening questions as well for COVID. This can increase call handle time by 5 to 7, maybe even 10 minutes. So what are the things we can do to automate some of those interactions and responses? And I think just to close there, it's really important though that I'm reminding myself that we have to have a clear strategy on consumer transformation, because if we try to do everything too fast, then we might not do anything really well or the right things fast enough.
Thanks, Marlena.
Yeah.
Chuck, switching gears a little bit here. Houston ENT is one of the largest private practice ENT groups in the country and has been in business for over 100 years. So clearly a lot has changed over that period of time. With the lens of being, really at the heart of Houston, what are you seeing in Houston with technology changing the landscape for ENT clinics like yourself and then specialty clinics more broadly speaking?
Well, it's happened overnight with everything happening with everyone. If you would have told us we would have been on telehealth, this fast a couple years ago, I said, no way in hell is that going to happen based on the way care was delivered. But I think the thing that makes it work is how intuitive the product is, right? I mean, if it's not intuitive, it's not going to be able to be adapted quickly. The patients are going to complain, the providers are going to complain, the staff's going to complain, and that impacts patient care at the end of the day. How quickly can you communicate? How quickly can you get the text message out? How quickly can people reschedule to say, hey, we're open, let other people know? It's just intuitive, and it's not complicated, and that provides access of care. Now, our standpoint has been a little bit different. We're a surgical-based practice, okay? So when this happened and we had to go into a shutdown mode of virtual care, that about crippled us, right? Because, I mean, if you look at our layout of our revenue, I mean, we're getting maybe 20% of our revenue from E&M visits, okay? 80% of our revenue is coming from ancillaries, surgeries, procedures, audiology, allergy testing, CT, radiology type stuff. And so for us, the idea of, doing telemedicine for our specialty is not going to work because, I mean, someone has a fishbone in their throat, someone's bleeding through their nose, there's an issue. I mean, you got to scope them. You got the things that we have to do as specialists that, unfortunately, telemedicine is not there. And what we found is when we went to telemedicine that it's not going to be as big of a part of our portfolio, but there's a part, and it's important because if a doctor's on call and someone says they're bleeding out after a particular procedure, they do a video call, telehealth, and they're like, yeah, someone's definition of bleeding out and the reality of that are different, and they can, talk to that patient, say, no, this is normal. You're totally fine. You do not need to go to the ER, so we kept someone out of the ER. And definitely during the pandemic, when we really were in the shutdown mode, there was some stories of anecdotes of some of the physicians saying that there was some growth on people's noses and things, and they were able to, it was very easy to see, and they were able to reassure the patient, like, you're fine. We can wait a month. You can come in here. This is not urgent. Don't go into the hospital. And so we saw ourselves using some of this technology to help keep patients out of the ERs. Now, another amazing thing about the technology is if you look at how we started seeing patients back in clinic on April 27th. When that happened, and I think someone said something about using technology, we were able to actually start slowly, but because of the way we work, now the patients were, filling out all their paperwork online before they came in. We would not see them. We didn't give them a choice. So our productivity started going up because we weren't having so many people in the waiting room because we're using Luma to have them do everything basically before they got there. And so now as we start doing, we're doing a number of we're at 6, 7, 8 build-outs, new build-outs going for expansion. And now because of the virtual waiting room, we're looking at saving a lot of money on our overhead because of the waiting rooms. We don't really see that they're really even necessary. So this is going to have a very big impact on overhead for practices as a new design of what we're looking at coming through for it. Because the patients, when the stories I'm hearing, when they're sitting in their cars waiting to get in, they're happy. They're on the phone. They're being productive. They're working. They're making their sales calls. They're doing all the time. They're listening to their music, talking to their kids. I mean, it's fantastic, and they're not pissed off when they come into the clinic. It's just been phenomenal. So having technology that's been intuitive like the Luma has, from the telehealth part on through informing the patients of their visit times. I mean, even I think someone said, we used it really quickly too to say, we had to change our cadence a little bit to say, it's a virtual care visit, but on top of that, don't come into the clinic, because some people are still trying to come in. But it helped clarify that. And it's very simple. And that has just been fantastic for us.
Awesome. Thank you, Chuck. Barbara, you are working with a lot of large health systems. Academic medical centers really help further their thinking around digital transformation, digital health strategy. What are you seeing with regards to technology, innovation, and really a focus on delivering care?
Sure, and thanks for having me. We do have a lot of academic medical center clients as well as health system clients, and really in reopening, I think there's 2 imperatives that are obviously and hugely important. One is to cut costs, because our the revenues have dried up so much in that bubble that we had, and so the other most important imperative is to grow. And how do you grow the business? And I think it really is what the conversations we're having is, how do we digitally engage more and more actively with the consumer community as well as the patient community? What better tool to do that with than Luma? So I think there's really 4 things that we keep talking about as ways to really gin up that growth and volume that I would comment on. One is to optimize, of course, telehealth and virtual care options, with so many of my industry colleagues have commented on here. But really the point about that I want to make is that there were so many bootstrapped efforts to do that during kind of March and April. I think one of the main things is almost to take a step back, look at the strategy, look at the enterprise scale of what you're trying to do. And to Marlena's point, really, how do you make it sustainable, scalable, and secure? So really looking at maybe 1 or 2 options, and how does that reliably open your access up like you want it to. I think also using data analytics, really going back and seeing which patients are underserved now because of COVID, which ones had appointments, which ones should have been seen for all kinds of chronic conditions or other ailments. Really use your data and go back in, and that's kind of what we're helping our clients to figure out as well. That way they can get back on the schedule, get back in the clinic, do the virtual waiting room in their car. That I love that idea that was just discussed. And then ramp up screenings again. There are still screenings that everybody has to do. For women, it's probably 3 or 4 a year. For men, it's the same. Really figure out, how do I engage with patients and consumers, non-patients that I want to convert to patients? How do I really get that message out there to make it safe again to come back into the clinics or imaging diagnostic centers, et cetera, to get those screenings done? And then, of course, ensure compliance, right? I wouldn't be a good industry steward if I didn't talk about compliance, of course, and security and compliance with the CDC guidelines and all of that. You're never going to create that safety for those patients unless you have a way, and I would say digitally communicating, this is how we're ensuring your safety, privacy, and all of those things. So that's kind of what we've been chatting about with our clients, is really what is that reopening strategy for growth, and how to do it digitally.
Perfect. Thanks, Barbara. One last theme before we turn it over to Kimberly, Mackenzie, Peter, and Jared. Really, what are you noticing with regards to patients and their sentiment? Are they ready to come back in for in-person appointments? What kind of appointments and services are they avoiding, or on the flip side, are they most willing to get back to? So, Dr. Chavez, I'll start with you there. Peter from Managed Healthcare Executive, he had a question in terms of knowing how the surge in cases this week has really affected your plans, and as we are headed for a new normal, but then have to switch gears, what impact has had that on you and your patients?
Yeah, so as I mentioned earlier, there's a huge disparity in internet access for some of our patients. And so one of our goals was to do a 40-60. And so it was going to be 40% in person and 60% continue to do telehealth. But that sort of went out the window beginning when we had the demonstrations where, our area got a little bit dangerous. And so we scaled that back up. And so definitely the surge in cases has really impacted our plans for that 60-40 move. We actually pulled back, and we're actually trying to do more of what we were doing before, which is the telehealth. But as far as the surge for testing, we got innovative. We bought a mobile van, and so now we're doing all of the testing outside of the clinic, and we're doing iPads so that people are getting like the other doctor mentioned. We give them an iPad, they get tested. We give them an iPad, they go back to their car, and then they have a virtual visit that way. And so we're trying to see patients as much as we can wherever they are. And we're trying to beef up our internet infrastructure. So we're putting, Wi-Fi outside of our clinics so that people can actually drive up with their cars and have their visits there. That will get rid of some of those barriers, or they can even walk up to the clinic and, we give them an iPad and they can be seen outside. But because our main goal is to keep our providers and our staff safe, we want to minimize the amount of people that are coming into our clinic, but that is very difficult with our population. So we're trying to figure out ways to see them in a safe way outside of the clinic. And this week we're actually giving it a bigger shot. We, spent over $100,000 in infrastructure to equip all of our clinics with really good Wi-Fi. But it's things that you have to do. And things are going to get worse, unfortunately, with the way that we're seeing all the cases rise. I don't know. I think you might go back to 80-20 or 80-10, where very few people are being seen in person.
So I'm not going to turn it over to our media panel, and I'll start by taking a question for each of them, and we'll kind of keep going as time allows. And if other questions come up, we'll have panelists chime in. But Kimberly, you're up. So, question you have for the panelists?
Sure. I was wondering, in terms of paying for these services, and whoever wants to respond can, should patients have some kind of, should they have to pay a copay for these visits, these telehealth visits, or should they, perhaps have to pay after a certain number of visits? What's your take on that?
I can answer that if you want, a part of it at least, from Houston ENT and allergy standpoint. Unfortunately, with the payers, just recently, they have really changed the rules, and any telehealth visits, they want to go through their own providers. And as a specialist, that's kind of hard to manage that way. So we've run into this a lot with a lot of the different payers because they've totally changed the rules, and it might change back because they had different guidelines on payments for E&M visits and whatnot. But it definitely has hampered our access to care for our patients. So we give them the option just to do a standard self-pay visit of like $80 if they want to do that for the telehealth visit as an option to keep the relationship up. We're also looking at just to keep the relationship with some of the patients too, having if it's called a no-charge visit telehealth before they come in, because most of the time when they're calling, it's not just a med refill for us. So they'll end up, we'll end up doing usually some type of procedure eventually. But it is difficult because of the way the payers are changing the rules for it and trying to hamper, I guess, some of the costs for telehealth and saving some money from our standpoint. Now, from primary care standpoint, I can't say if that's an issue, but it very well could be based on the payer and the plan. That's what's dictating some of the reimbursements that the physician offices are seeing.
So are you saying that for a while they were covering the full cost of a telehealth visit regardless of, whether
Correct.
a patient was out of network?
Yes.
Okay.
But that's all changed.
Yeah, the rules keep changing. This is with Houston Thyroid Endocrine. So we're a specialty outpatient group. And pre-COVID, we figured out by accident and trial and error which insurance is paid what, when, for telecare, and it was very confusing. And so we'd exclude care for certain people and include care for other people, and tell people, well, Blue Cross requires you to go there, doc in the box of their own. Sorry, otherwise you have to come into the office. And there were all kinds of weird requirements. Again, all artificial mechanisms that make no sense. And now the rules are even more confusing because they're saying we're paying for everything, but sometimes they do. And when we look at the books, we're really not. The biggest problem is we don't know who to collect on. We don't know, should we collect on the self-pay patients only? Should we collect on the people with deductibles only? Will all Blue Cross plans pay? Do I need to dedicate staff to call people because there's no mechanism in any telehealth platform right now that's good at connecting the practice management system balances what each insurance is needed to pay or not? So because they've changed the rules so much and there's no link, like it's very hard to say, here's a link, here's how much you owe, because we hardly half the time know, and patients don't. There's no way to get it to our system. So it requires a lot more manpower than even a in-office visit where you're right in front of the person, you say, here's your credit card, and whatever it may be. But now we flipped from collecting on everything to saying it's impossible. We don't know if we're going to be giving tons of credits back. We'd rather just not overcharge the patient. So it's been difficult, and if they do continue to require copays, I don't know how I will collect it on all the people. There's no way to do it. I don't have enough staff to continue to call repeatedly and say, go to this link, go to that link. We're not sure. Let me call you back when you get a credit card, because I'm waiting. I'm in the waiting room waiting for the patient. So do I wait for them or move on? It's a little weird. So I'm glad that they've extended officially to extended like Medicare and some other plans to not require a copay. It's made our life a little bit easier, especially because my staff's not even in the office. Half the time they're at home. So how do you do all that with copays? It gets a little confusing.
Agreed.
Awesome. Mackenzie, over to you.
So my question kind of has to do with, obviously, March and April, there were a lot of changes that happened really, really quickly. Healthcare systems, investing in new digital health tools or scaling out, building out what you already had. And kind of to Barbara's point, I feel like, maybe kind of moving forward, healthcare systems are going to be taking a step back and kind of assessing, what's working, what's not, where should I continue investments, where should I maybe not? And Chuck, like you were talking about, you've seen some like success with the virtual patient rooms, but maybe on the telemedicine front, that might not work as effectively for you because you need to be more hands-on. So I'm guessing, like, with your experiences so far with kind of investing in telehealth and maybe other tools, patient capacity forecasting, other analytics, are there tools that you're looking at that you can say, yeah, I'm going to be continuing investments in this kind of technology and these kind of tools? Or are you going to kind of be thinking of a strategy of assessing that moving forward? What do I need to continue investments in, or what do I maybe need to pull back on? I guess, what's that going to be looking like moving forward for you guys?
No, we are totally looking at that. And I think one of the issues that has been apparent when we, because we're tracking all the time when the patient arrives, the time they're in the exam room, the time they check out, all these things are being analyzed. And I think one of the challenges, and it's not just, I think it's all telehealth platforms, because if you have a patient that you're doing a telehealth visit and they're in a 10-story apartment or in the very back, and they have their iPhone security is high where it won't allow access to the microphone and the video, you can see when you have a 10 o'clock appointment and they can't see you, they can't hear you, all of a sudden you have like a 5-minute telehealth appointment that drags a provider into 25 minutes. And that's when the technology kind of, the platforms, and it might not just be that, it might just be that person's iPhone way back where they're way away from a cell tower or don't have Wi-Fi in their place. I mean, the barrier of care is just that access, right? So that's when it gets very expensive for a time of a provider, and they know it, and they're and so we've had to get other people involved to make sure the person's teed up and ready to go and they can see and hear them. But then you have to look at, like you said, the analytics of the cost of that FTE to get involved to do those type of things. So we're looking at it. We definitely, it's here, it's in our system. There's a lot of value for sure, because once everything, if you click and you're in and you're out in 5 minutes on that call or less than that, fantastic. But we do have challenges, and we feel that it's going to get better because, this just exploded, right? So we feel that the capacity in the next 5 years is going to help support this more and more as we go forward. So we're going to be patient with it, just like we implemented any technology, EHR 10 years ago, all the pains and sufferings of that, e-prescribing, using patient portals. So we feel that the infrastructure, the foundation is going to continue to be built up with a lot of the other companies to help provide this, because it is such a value. It really, if you have there was someone that was sick in Colorado and had an issue, and we were able to telehealth with them really quickly and just reassure them right away. So we don't want it to go anywhere. We're gonna invest more time into it. We're not gonna walk away from it, but we're realizing there are limitations on it for sure.
Sri, I'd love to get your perspective on that as well, just from the perspective of a large health system, areas of focus today and areas of continued focus from a technology investment standpoint. Sri, are you on mute by any chance?
I'm on mute now. Can you hear me?
On mute now, yes, we can hear you now.
Okay, good, thank you, sorry. So from our perspective, we're doing a lot of these things across the board. Of course, we are investing a lot more in digital. That is the reason why I even got hired in Franciscan. The whole concept is around trying to change the way we treat patient behavior. When I call patient behavior, it's not just the patient behavior only on one side. It's helping the patient behavior both in and out, right? Completely. We are looking at from an ambulatory perspective, or I should say ambulatory, on the outside perspective, you're looking at remote patient monitoring. You're looking at fitness information that you can feed into what we call patient-generated health data. We're looking at a more cross-pollination of socioeconomic factors that bring in that information to understand the whole patient, right? That's one thing. And as we say, right, the 90% of the healthcare data is outside healthcare, right? So we're going to pull all of that information, create what we call a connected care platform, right? That is where organizations like ours will really understand truly how to take care of patients in a holistic way rather than in an episodic manner. And digital is part of that fabric. And we believe that weaving that fabric in a much more robust connected care platform where we get data from multiple information sources. The EMR has got only some aspects of it, right? Not everything. And several EMRs have got several ways to gather data from both from the diagnosis side as well as from the patient side. So our goal is to figure out how do we harness this data through some sort of a model. We can create an AI-based personalized care platform for that patient. Number two, utilize what we would call monitoring services that will do video visits at the flip of a coin based on blood pressure data or, pulse ox data, stuff like that coming back into our system. And number three, how to avoid that ED visit when the patient is in some sort of an acute chronic care scenario. So those three areas are where we are focusing most of our lives on.
Thank you.
And Adnan, I'll weigh in there. I'm glad to hear all these requirements because as the kind of premier provider of a telehealth system, that's what we're looking at. We know that it's got to include some of these features to make it seamless and easy. It's got to have a way to do payment, right? It's got to be simple and it's got to be secure. And it's really got to be easy to do troubleshooting. If somebody's having trouble connecting, it's got to be a quick button. It may use AI, it may use capabilities to quickly troubleshoot, reconnect, reestablish the visit. So it's great to hear everybody validate where we're going.
Thanks, Catherine. Kristen, do you want to share something real quick?
Yeah, and before you jump in and turn it over to Peter, Peter, you're next for questions. We do, I know that we have the schedule going up to the hour, 12 noon East Coast and 9 a.m. Pacific time, but we can go over if anybody has the time, Kimberly, Peter, Mackenzie, if any of you want to stay on longer and have a few minutes beyond, that's great for any of the panelists who can. For those who have to jump at the hour, that's fine. Kimberly, Mackenzie, and Peter will follow up with you after this. You can have access to any of the panelists here one-on-one. We're happy to facilitate making those conversations happen. So we'll also make sure that you get all of your questions answered if you don't during this hour. But again, we have 30 minutes beyond this if we need to stay on.
All right, Peter, over to you.
Yeah, hello, everybody. I guess I have two questions. One is a follow-up, and I just want to make sure I understand this from the physicians. Were you saying that payers were paying you for E&M visits conducted virtually or telehealth, and that they've stopped doing so and steering those calls to the national telehealth companies and therefore taking you out of the telehealth game, so to speak, and at least in terms of evaluation and management? And my other question is, I was listening to a conversation yesterday where the panelists were arguing that telehealth is really only going to work and become sustainable if we move to more value-based payment. Something gets called different things, but capitation is a word that's is a term that's sometimes used. So I'm just wondering how you folks see the relationship of telehealth and value-based payment and contracts.
Peter, if I may, let's start with the second question you asked, and I'd love for Adam to comment. I know they've done extensive research with providers and health systems and clinics all across the country. So Adam, if you want to chime in there, and then we'll hear from Dr. Jogi, Dr. Chavez, and Tashfeen around from the direct provider perspective.
Yeah, great question. And I really think the dust is settling. We're all trying to figure out the new normal. Everyone is still trying to understand. A lot of organizations I talk to were having success with payers that were seeing reimbursements, but many were still trying to solidify a strategy prior to COVID, and even more so now. And so without having done specific research on the reimbursement models and where they are, I'm sure these providers could answer better than me, but I would say that even more so now, structures are being redefined, governance is being redefined, and I think reimbursement is being redefined. So I believe there's national support now that will get there, and that there's opportunities to improve, but still a lot of questions to be answered is how I would respond.
Dr. Jogi?
So the first question of the payer. We were answering the second question, right? About so my thought on that is that the value-based concept I really don't buy into, because that only exists if we're talking about siloed healthcare, meaning I'm an endocrinologist, I can see 25,000 patients a year. Are there 25,000 patients that need to see an endocrinologist at whatever rate? So if it's about price and utilization, then open up the borders. I mean, I've been trying for 5 years to get a license in different states to practice medicine. I get patients from Florida and Hawaii and California, and I have a cheaper rate than they do. Where are these rates coming from? Why, if we had no borders, even just in the US for care, I feel like that solves a lot of problems. And, as soon as a patient, and overutilization of care and the costs of healthcare are administrative, they're not the physician. And it is administration that is created to create the silos. So break down the walls and the prices go down.
Yeah.
But I'm not an economics major.
Yeah. Yeah. So from our standpoint, I think that telemedicine is here to stay, right? We opened this genie, and now everybody has to do telehealth. But I think that one of the senses that I get is that Medicare is where everybody takes their cue for pretty much everything in billing, right? They are not keen on having telehealth be a major or play a major role, at least in doing all those HEDIS measures and all those things, right? Because it's really difficult to do that, and we found that out, because we measure, colonoscopy, all the different health measures, and everything has taken a dip. It's really difficult to do that through telemedicine. People have to come in for certain things for you to do it, and so I think that there is going to be eventually, once the pandemic dies down a little bit, there will be a little bit of a hesitancy for payers to pay you, even if we get really good at doing telemedicine. I think that there, because I know that for behavioral health, I'll give you an example. Medicare had given a mandate that they were not going to pay for telehealth as a face-to-face visit as of, I think, July 1st or something like that. And so a lot of the payers for behavioral health took that cue, and they started sending letters to us saying, hey, you are not going to be able to do telehealth, and we're not going to pay you the same rate. It's going to be a lot less. I think it was like $15 or something like that per time, which doesn't make sense. It's just, it's not sustainable. So I think that we need to look past that and figure out a way to virtually see patients within our four walls, which is a lot more time intensive. But we need to be prepared for that. We need to prepare for telehealth not being a reimbursable, there's going to be some reimbursement, but it's not going to be the same. At the end of the day, I think that it may be a negative driver, right, for providers to say, hey, we're not going to do telehealth because it doesn't make sense. We got to bring people back. So I hope it doesn't happen, but I think that we need to be prepared for that eventuality.
Thank you. Kimberly.
That was going to be my question, actually, and I'm sorry I have to hop off now, but I really appreciate everyone's expertise. This was great. Thank you.
Thanks, Kimberly. Mackenzie, did you have another question?
Sure. So actually, obviously, you all have been talking about kind of the telehealth, regulation changes. There's been so many that you all have been having to see and deal with through this. But I guess of the changes that have been made to enable you all to practice telehealth and get patients treated remotely, has there been anything that's like really stood out to you as like, yes, this has really helped me, and I want to see that continue? Because obviously there are conversations about making some of these changes permanent. Even CMS last night proposed a rule to make some of their changes permanent, and the Senate Health Committee met last week and talked about making some of these changes permanent. So I guess, is there anything that's changed that's been impactful to you that you would want to see continued and made permanent?
I think for us as FQACs, the just pay us the same rate as a face-to-face visit, and I think that that's a driver for us to reinvest back into the technology so that we can continue providing care. But I think that that is right now contingent on either the state or the federal government calling an emergency, right? That's what it is. So as soon as the emergency goes away, we are fearful that no matter what we do, they're going to go back and they're going to say, well, you go back, you need to make it work, right? And so what happened with all this money that we invested into telehealth, into all these technologies that are allowing us to see patients in their home? So that's a little bit frustrating. So it would be nice for us to come up to a medium, and then say, we're not going to pay you 100%, but maybe we'll pay you 80%, right? So that it's worth our time, it's worth our efforts to continue to invest in this type of technology. But that is a huge fear. And as we move towards reopening, and now probably not, right? Because all the cases are going up. So this might continue a little bit more, but it is a big worry that keeps me up at night.
Actually, yeah, this is Sri. So we've been talking as a nation about cost of healthcare, right? If you take a step back and look at where we have come from in the past few months and looking at long term, I
think we lost you there.
Is to get care within the right time frame and go from there, right? That is important. That in some respects reduces the cost of care rather than patients going to the ED and getting seen in the ED. At least they can be seen ahead of time and get care in a much more easier fashion. The proliferation of devices and the data that they generate that can be assimilated into the healthcare system also creates a level of drop in anxiety, so to speak, from a healthcare patient perspective to bring that cost down. Several what we've called symptom checkers or all those AI-based technologies that we have today that allows patients to, answer questions and get feedback and make the right determination of care as well, helps improves overall, function of the human body. That helps them as well. So if you look at all of these changes that we've been through in the past few months, in the longer run, this is going to generate a lower level of care across the nation, in whatever parlance. Opening up the borders for physicians to do telemedicine visits was a hindrance. Hopefully that will stay permanent, that will continue. All of these barriers to better healthcare across our states will kind of be slowly what I would call disintegrate in some way, shape, or form, delivering a much more robust healthcare system for the nation. And that, I think, is what we should be looking forward to rather than, dwelling on the pandemic, looking at the future, kind of the forecasting the future, trying to figure out how we can make the most what we've got today.
Yeah, and I do think what Dr. Chavez was saying, access to care is important from a specialty standpoint. It's medical economics, right? So if you're analyzing your contracts and what you're getting paid, unfortunately, we're going to seek out, the patients that we get paid on because there's a lot of overhead here. And that's like the problem with, Medicaid patients sometimes. It's hard for them to get seen by a specialist because of the rate of pay. And if you put this barrier up, then more access to care to specialists, it hinders it. So, it's not helping the healthcare situation, so it is problematic.
I wanted to throw in one thing. The changes that I really liked are everything that CMS did to get rid of provider site requirements and coordination and rural, all that stuff they got rid of. That was awesome. And then if they can keep extending the no copays and no, we're covering all COVID stuff, those two things are very useful. Those are my thoughts.
Yeah, one thing I would add is looking beyond some of the billing issues is that I think as a nation, prior to COVID, and this is a silver lining I'd say when the COVID is that I think we as a nation, both on the provider side and the patient side, are certainly more comfortable with telehealth. Whereas if you had asked a lot of folks before, both patients and providers would have been like, no, I'm not sure. But now we were kind of thrusted into it. And so just in terms of patient sentiment and provider sentiment and our comfort in doing it, I think that had a huge impact. Now, of course, the billing landscape is going to be kind of a insurance billing landscape is going to be something we're going to need to navigate. But I think at least as a nation as a whole, we're ready to embrace to a certain level more than we were before. And I think that's important because a lot of that things, even though if the legal thing is there, if the patients aren't ready or the providers aren't ready, that'll be a no-go.
Agreed. That's perfect. Yep.
Okay. Well, thanks everybody. I think we'll wrap up now. And Mackenzie, thanks for your questions. Our team is going to circle back with you to see if there's anything else that you need. Again, if you want further time with any of the panelists, we'll coordinate that. We'll also send out a recording of this once we have that, either today or early next week. Want to thank all of the panelists who are still on, who took their time today on a Friday to offer their insights and expertise. We really appreciate it all. And have a great weekend, everybody. Stay well, stay safe, and stay healthy.
Thank you.
Thanks, everyone.
Thank you.
Thanks,
Enjoyed it.
Seeing you all.
Bye-bye.
Bye.